Hey, EO Live, thanks for joining us today on this EO Talks. Again, this is a COVID update. We do these every week, and every other week we are talking to CHD about the medication-assisted treatment program. I've struggled with that mouthful, but that is a program that assists folks that are addicted to opioids in one way or another. And today we are continuing that conversation with Lindsay and Nikki. And thank you guys so much for jumping on with me today. Have you been outside yet? It's beautiful out there.
It's warm.
Yeah. It's great that it's not raining or snowing.
Yeah, I know. I was earlier. I went into a store with my coat on, and I thought, should I leave it in the car or not? And by the time I got out to the car or back, it's like, man, I mean, it's just warm. It's really nice, beautiful weather that we're experiencing. So, well, thank you guys. So this is the medication assistant treatment program. Medication assisted treatment program. And we talked, so we had a conversation with Aaron Griggs. It's probably been a month ago. And then 2 weeks ago, I had a conversation with Jamie, who is the overall person of this particular program. And now it sounds like we're kind of moving, having a conversation with you guys. You guys are a little bit more of the nuts and bolts of what happens on the internal part of the program. And that's, as we've gone along, I've asked that question a couple of different times, is like, okay, well, what do people experience? And for our audience that is watching, just want to remind you that you have the opportunity to put your questions in the Facebook comment section. And we would love to have those questions, be able to address those questions. And even if we're not able to address them today, very often CHD will go back into the conversation afterwards and either address your question directly, or if there's something that we don't know, then we will bring that up in our next program. So let's Lindsay and Nikki, why don't we start with Lindsay? Describe to folks what it is that you do, and then how you and Nikki work together. And let's start again with, so the patient, they dial the phone, and we'll put that number up here in a bit. They dial the phone and they reach out. What happens when who do they connect with? Take us through this process a little bit.
Okay, perfect. So my name's Lindsay Winburn. I'm the medical assistant for the adult behavioral health team, and most importantly, the medication for addiction treatment. And so the client will call our Hope line, and then they will get Jamie, who is our coordinator, and Jamie will go through an assessment with them and make sure that they qualify for an opioid use disorder. And then once that is finalized, she transfers them to me, and I coordinate between the prescriber's schedule, so the psychiatric nurse practitioners, and Nikki, our RN, to get them scheduled first for a phone intake with Nikki, and then the actual appointment with the psychiatric nurse practitioner. Following that, shortly after, they see Nikki in the office for an induction. So Nikki, if you'd like to take it away.
Okay, so I'm Nikki. I am a registered nurse, and I also work for the adult behavioral health team and the MAP program. So once Lindsay tells me that someone needs what's called a nurse intake, I call the client, and I do kind of like when you go to the doctor's office and first you sit down with someone and they ask you a bunch of questions like what medications you're on, past medical history, and most importantly for this instance, their past substance use history. I get all of that information compiled, and then I send it to the psychiatric nurse practitioner. They then meet with the client usually later that day or the next, and have their visit with them. And after that, we schedule what's called an induction. And an induction is when we start somebody on Suboxone or buprenorphine. That's where I go in.
And we'll talk more about that here in a minute. So Lindsay, so then are you kind of the ringleader, the phone operator, director? I don't know. Are you kind of the person that, I don't know, describe to help us understand what it is that you do with folks and how you help them route them to the right people? So.
Yeah, absolutely. So usually I am a frequent contact of the people that are in our program. I'm able to essentially filter out what they need and to see if they, need to talk to Nikki about it, if it's something simple that she can fix.
Phone operator,
if they really need to follow up again with the prescriber. So I kind of, am a little bit of the hub in terms of once they are actually in the program. And I make sure that their medication has actually been sent to the pharmacy and that we have the right dose in the chart and that we have, their urine drug screens and just kind of behind the scenes, making sure everything runs smoothly for Nikki and the psychiatric nurse practitioners.
So when they first come in, let's talk about, and Nikki, you might be the one that talks about this. So talk about the urine drug screening and why that is important and how that affects, how that helps determine their course of treatment.
Okay. So the urinary drug screen will show us if they've recently used an opioid or other substances. In order to start somebody on Suboxone, they have to be without opioids for 24 to 48 hours. So we use that urine drug screen to confirm that they don't have an opioid in their system. And then further down the line, we use that to confirm that they are taking their Suboxone.
So that is essentially a chemistry look at what's going on the inside of their body, as far as whatever drug intake they might have. And so then describe induction a little bit. What is that process? So, and again, let's go back to the very beginning. This is a program that is for people who understand and recognize that they have a problem. No one's holding a gun to their head. No one's forcing them to do this. And so they're entering into this program because they understand that they either have a heroin problem or they have become addicted to opioid drugs because they've been recovering from an illness and they overdid it, or I don't know, whatever the case might be. And in the past, the conversation, if you're interested in this, you can look up the conversation that Jamie and I had last week or a couple of weeks ago, and we talked quite a bit about how opioids attach themselves to the body, how people become addicted to them, and so on and so forth. So anyhow, the folks that come in, they're coming in of their own free will. They're trying to find a better place than where they are right now. And so, and the Suboxone, the question I asked you yesterday, which is how we're using a drug to help people get off of a drug. And so, but the question I had is so how is Suboxone better? Which I think is the place where people really need to understand. Absolutely.
So Suboxone is better in that, first of all, it's not illegal.
Yeah,
so you're not going to get arrested for having Suboxone if you have a prescription for Suboxone. Second, there is a component to Suboxone. There's two medications in it. One is the buprenorphine, and then the other is Naloxone. And Naloxone is just another name for Narcan. So it makes it so that you can't really overdose on Suboxone, and it makes it a lot harder that if you are taking Suboxone to overdose. So it protects the user from basically killing themselves.
So if I have a loved one that's maybe struggling with these issues, and I've not been in that situation, one of the things I'm worried about is them overdosing, or getting a bad batch of something if it's an illegal drug, and so then at the very base of it is that it's going to be hard for them to overdose on Suboxone. So now let's talk about induction. But to do induction, they have to get to a point where they're experiencing some withdrawals. And so talk about that process. So they come in, they say, okay, I want to do this. And then, so talk about what they experience and what happens and what's required of them.
Okay, so I like to do in-person inductions, just from a nursing standpoint, because there's a lot of visual cues with any patient. They come in and they're usually in active withdrawal, which is miserable. They don't feel good. They are in pain. And the reason they have to be in active withdrawal is because if we give them Suboxone when they are, like if they've used heroin or another opioid in the last 24 to 48 hours, we can send them into what's called precipitated withdrawal, which is a medical emergency. So we like to confirm that they haven't had any opioids for 24 to 48 hours. They come in and they sit with me, and I take their vitals and do what's called a COWS assessment, which stands for Clinical Opioid Withdrawal Scale. And they need to be on a certain level of withdrawal in order for me to even give them their first dose of Suboxone. I give them a dose assuming that they're at a level that is deemed adequate. And then I monitor them for 15 minutes after, and then another 15 minutes after. And then I let them kind of hang out for about a half an hour after that first half an hour. And then if they are still high enough on that COWS assessment, they get another dose of Suboxone. And we kind of just keep going until we find the level that makes their withdrawal symptoms go away and their cravings go away so that they don't relapse.
So you're essentially determining the dose of Suboxone that they need.
Yes.
Okay. And so we're going to have a conversation next week with the nurse practitioner. Talk about what is their role during this process when you're doing this, Nikki?
Okay, so usually I am it's kind of an instant messaging situation with most of the prescribers. I report where the patient is on the COWS assessment, like they scored a 6, and how the patient is feeling and what I can see, because a lot of withdrawal is very physical. They sweat, they shake, they vomit. It's a lot of physical things and not reported things. And after each dose, I let them know every time I assess them, this is their vital signs, this is what they're experiencing, this is what I'm seeing. So I'm pretty much in contact with them all day. And then once they reach a certain level, me and the prescriber or the nurse practitioner usually decide, okay, this is a good dose. And then the prescriber will write a prescription for them.
So then they're able to have that prescription right away. I mean, so then from that their cravings is able to be satisfied by Suboxone from that point on. So they're going to be able to experience immediate safety. In other words, know that they don't have to go do something illegal to get drugs, or they're going to be immediately out of that cycle, whatever that might be. They're going to get a prescription to stay in that place. I mean, how long? I mean, do they get a prescription and they walk out the door and they go to a pharmacy and get Suboxone? I mean, what's the process there?
I'll let Lindsay start that part.
Okay.
Perfect. So we write the prescription and we send it electronically to their pharmacy. Everyone starts out on tier 1, so they get a week's worth of their medication. And then we have to have a UDS or a urine drug screen to continue on giving them a week. We want to be able to monitor and make sure they're still on the medication, make sure that they aren't taking other medications or illicit substances. Because overall, we want the client to be safe. And we want to make sure that what we're prescribing is going to keep them safe. So yes, they get a week. We hope to see them again at a urine drug screen.
Yeah. But a part of that is accountability. So if they're entering into the program, they're voluntarily going to subject themselves to routine urinalysis exams, and because that is part of the program.
Yes, absolutely. And we like to get those randomly. We actually have a call-in system where every client has their own number and they call in to assure. And if their number is on that day, they go in and provide a sample so that we're catching people off guard essentially. And so it's not like a scheduled thing. So you could plan just in case maybe it's not as clean as we'd like it to be.
Yeah. So does, I don't know, talk about your personal experiences with this. I mean, clearly you have patients and you have to protect them, but how do you personally feel? Let's start Lindsay first. How do you personally feel with the people that you've been able to help? And I mean, how does that feel to you personally? How do you experience that?
I mean, it's amazing. I mean, essentially when we get them started, we've saved their life and we've helped them on their road to recovery and can continue to support them. I mean, through the highs and the lows. If we have someone that relapses, we're there to, help pick them up, get them back where they should be. And overall, we're just this great support system for them. And them wanting to get clean and get on the medication is such a huge first step. And it's such a proud feeling when we're able to help someone accomplish that.
Yeah. And how about you, Nikki? What are your feelings about that?
So I come from it with a little bit of lived experience. My sister passed away from a heroin overdose about 5 years. So I have 5 years ago. So I have a little bit of personal stake, I guess, in this. So when first dealing with clients, it is rough for them. It is really rough, and they usually don't have a support system. So being a part of that support system is not just amazing, but it's almost refreshing to them. And it's nice to see them grow in their recovery. Because I personally haven't struggled with a drug addiction, but I've seen it, and I've seen what it does to a person's support system, and it's basically gone. So they need us to be that support system for them.
That's awesome. And I can imagine that when everything goes right, it's wonderful. When you probably have those sad stories too of people who they don't quite make it, or they try multiple times. And you have some of those people that, try over and over again and finally are successful. Have you guys accumulated those stories too?
A couple of them.
Yeah. So one of the most interesting things that is a part of this is that opioid addiction can be something that can happen to anyone from the standpoint of they just become addicted to a medication that they were taking after a surgery and so on and so forth. And again, in general terms, are you seeing that? Are you seeing that how that negatively affects people in our community? So totally atypical people, they're not a illegal drug user per se, but now they're in this situation. I don't know. Do you have any stories that you could kind of generically tell me about that?
I'll take this one, Linz.
Okay.
So got to be really generic because of HIPAA.
Yeah.
But there's a lot of stigma, I guess. People assume that, you made a choice to use a drug, so now you're addicted. That's tough. And it doesn't work like that. It really doesn't. There have been multiple clients that people would never guess have an opioid use disorder or other substances. I would have never guessed. And then there are the people that like you see on the street and you're like, oh, they probably use drugs, but they weren't that person before they got addicted. You know what I mean? Like,
Yeah.
They weren't an addict before. They weren't homeless. They weren't all of those things, but the addiction has destroyed that.
Right.
So just because you don't think somebody has an opioid use disorder or any sort of disorder doesn't mean that they don't.
Well, and the issue really is that you can take someone who might be a totally atypical drug user and I'm sorry, I probably don't have the right terminology and so on and so forth, but all of a sudden they are addicted. And so they find themselves making compromises in their life that they never, ever would have made, ever. Mm-hmm. They're making up illnesses and trying to get more pain medication, or they're rifling through someone else's medicine cabinet looking for, this is totally in the dark for me, but these are the things that I would imagine someone who you would never expect. They're because of the shame, because of what's going on in their life, they're doing what they can because they have this craving, and they're trying to patch it. They're trying to get by,
Right.
Yeah.
And I don't think that what people need to realize is nobody wants to be a heroin addict. Nobody wants to be the person on the street that people look at and go, oh, you use drugs. But withdrawal is not, people describe it as a flu. It is horrible watching people in active withdrawal. And think about like the time you were the sickest. You would have done anything to feel better. Mm-hmm. And they know what will make them feel better. And It's that drug. So, I mean, I've had the flu before and I probably would have done anything to make it go away. And I think that people need to realize that it's not like they chose that. They didn't wake up one day and be like, I think I'm going to inject heroin today. Right.
Well, and a few years ago, I had pancreatitis and was kind of struggling with it. And I couldn't decide what was really going on. I went to the ER and, they said, well, we think you have pancreatitis. I'm like, well, are you sure? Because this doesn't seem like that much pain, and then they gave me Dilaudid, and they did not dilute it at the time. So it just like, whoosh, it just came this, but all of a sudden like that, I realized how much pain I was in, and then in my ignorance, I decided, well, this is, so if I just take pain pills and don't drink anything, is this something I can manage at home? Mm-hmm. And I became very aware. I mean, I went home and about 12 hours later, I was back at the ER and was admitted. But I think about that. I think about that. Once I experienced being away from that pain, then it was like, okay, this is important to me. And I'm sure that some of those folks that are going through withdrawals, they're feeling that same thing. It's like whatever it is they're experiencing, they found something that placates it and they want to get back to that point. Yeah. Yep. All right. Well, this is great. Is there anything that we missed or that we need to hit on?
Okay. I have something.
Yes.
So if anybody watching is worried about a family member or knows somebody that could use some Narcan, we can get you some Narcan, which is what reverses an opioid overdose.
Okay.
So if you need any of that, just call that phone number.
All right. Great. Well, thank you, ladies, for jumping in today, and thanks for what it is that you do. And I'm sure that I hope we can get to talk more. And Thank you for just loving people and helping them through this. And because I can tell both of you, clearly you have roles and part of this is your job, but you wouldn't do this if you didn't care about people. You wouldn't do this if you couldn't see that it was helping them in some way or another. So I really, really appreciate that. Anything else you want to add before we take off? All right. Well, thank you, EO Alive, for being with us today. And we'll see you next time right here.